And the quality is the third pillar here, is about the safety and effectiveness of the intervention. So the quality mostly addressed by research, by advocacy, by education, and by quality improvement projects. So this is all about the global surgery. And there is as well new other definitions, including the rural surgeons. Those are the providers of surgical services in rural areas. Rural surgeons need to be backed by the academic global surgeons community. The academic global surgeons community, those are the people who put the policy in place, research in place, fund in place, who are the people who did the advocacy in place. So in order for the rural surgeon to be effective, got all the facilities in place, he need to be backed up by academic global surgeons. Those are the reference for these definitions. So why we take a lot of time to understand the definition of the global surgery? We define global surgery because we need to set our objective, our priority, and our strategies to solve those issues of the global surgery. Because you all know that there is MDG and there is SDGs to solve some specific issues. And those MDGs and SDGs are put together because people know where they want to be. For the surgery, we need to define the surgery, then after that, we can put our objectives and priorities and strategies. And the definition as well for communicating the goal and vision, and the definition as well for channeling the resource, funneling the resource to where it needed the most. Then ensuring activities of actors and as complementary rather than competitive, because nowadays there is plenty of global surgery organizations, and most of those organizations are competing either toward the fund or competing toward the outcome or competing toward the implementation. It is better for us to have a definition in place, a goal in place, then each of the organization can come as a complementary rather than as a competitive. This is the understanding of the global surgery in general. Then a very brief context about the actors of the surgery in Sudan, the main decision maker of surgery in Sudan. We will start by the Sudan Medical Specialization Board as the main body responsible of the surgical training in Sudan. And the surgical training program in Sudan is 5 years, 2 years of core training and 3 years of specialty training. And the second actor is the Ministry of Higher Education and Scientific Research. At the end, I will speak about how the research is very important and how the research will improve the global surgery and the surgical services. So regarding the Minister of Higher Education and Research, it is the body that is responsible of allocating the government fund for the higher education and for the research as well and the innovation. And that's why they have the National Council of Research. This council is responsible of the partnership between the academics and exchange programs and between the public-private partnerships for research funding. And the other key stakeholder and actor is the Minister of Health. Minister of Health develop the national policies and the national strategies for all the health-related disciplines, including the surgery. By surgery, we mean all the interventional disciplines, surgery, obstetric, anesthesia. And Minister of Health is the body responsible of funding the resource allocation for surgery and collaboration with international partners and organizations. And the Ministry of Health is the body that advocate for the surgical funding across the other political priorities, and the Ministry of Finance to fund the Ministry of Health more because the surgery need to be funded, not like the others because there is no global fund for surgery. That's a bit of brief about the surgical providers and surgical services in Sudan. Then we need to discuss a bit about the challenges And these challenges might be a source of support for Sudan or area where we can seek support for Sudan, especially during this conflict. Before the conflict, there was challenges, but at the moment, the challenges are more than previously. So there is shortage of surgical workforce. By surgical workforce, we don't mean only the surgeons, the surgeon, obstetrician, anesthetist, and the scrubbing nurse, and all the surgical team. So the number of graduates by the Sudan Medical Specialization Board are not sufficient to the Sudanese population based on the population density needs. And the conflict has affected this by increasing the pushing factors people leave the country and reducing the pulling factors of people who come back from other countries to work in Sudan. So our colleague Bashiri, this is the study just done, published by 4 months ago. He surveyed the surgeons and registrars of surgery, and here is the 2.2% were internally displaced. Those are as either surgical consultant specialists or registrars, and 33.3 of them had left the country already. Then we have 51.1% were no longer practicing surgery in Sudan after the conflict. Among those people, 75% are those who left the country, and 20.8 or almost 21 of their hospitals are out of service. And here are some of the data, and 4.2 found it unsafe for them to go to their hospital. So here are some who leave the country, some who internally displaced, those red people, and those who left the country. This is a very huge number. And who have left their places, the internally displaced to other place, hospital are not working and not safe to travel. In terms of the limited access for surgical care, we have other as well, some data about recent data about the post-conflict era. The concentration previously, before the conflict, the concentration of surgical facility mainly was in the big city. This signifies the disparities of access across the country. But at the moment, most of the cities are the same as the rural areas, and approximately 68% of the hospital where the surgical operations was being running are now out of service, and 88% of the hospitals affected, 60 of them were inactive, and only 28 operating surgical hospital are fully or partially working at the moment. Why access is important? Access is important because, as we mentioned previously, the access is the key for surgical service provision. And if we look at this mixed study done by Dr. Al-Hadi Miskin, it is recently published, I think a couple of weeks ago. This study highlighted some of the main adverse outcomes of the pregnancy and the delivery. And the problem of access was, the odd ratio of the problem of access was 2.35. It is very high, significant. And if you don't have access, then it is 2.3 times more adverse outcomes than the normal people. So the access affecting the outcome of delivery in the current time. So those people who didn't have access, he interviewed them, and this is part of the outcomes of the interviews. One of the candidates said, I was 6 months pregnant when the conflict started. The nearest hospital was closed, and I couldn't find a way to transport and take me to the next hospital. I had to rely on traditional medicine, which is you all know, which was not sufficient, and I was scared and worried about my baby health. This is one of the issues around the access. and challenges faced by women accessing maternal health. If she want to access, she is afraid due to the gunshot outside and due to transportation, and there is no one to support and to help. Inadequate infrastructure was one of the main challenges as well. Lack of essential equipment, reliable electricity, and proper operating rooms. It is the issue. And this is a study done by Rashid as well. Professor Rashid was one of the authors as well, assessing the uh, assessing the training program of surgery. And this was, I think, before the conflict, and it was limited availability of essential facilities for the trainees. That was before the conflict. At the moment, I will assume that this is even more than previously. So registrars lack the access to surgical training facilities, lack the access to research facilities, and those are their main issues. Economical challenges lead to limited the funding for surgical services, and many of the surgeons and the registrars and the surgical providers, including the obstetrician and the anesthetist, they flee the country toward better living opportunities. So that was our challenges in Sudan, and I'm sure there is a lot of challenges there, but this is the main challenges related to the global surgical context. If we try to look for the opportunities, we can say the telemedicine and teleconsultants consultation. It started by some of the organizations and some of the diaspora. They did some of the consultations through telemedicine and teleconsultation. This will provide or will support our country will give us the capacity to continue toward this one, and even after the conflict we can upgrade these services and we can make the best out of it. We have some potential work in the future: robotic robot surgery and virtual education platforms, which we have done last year with the colleagues from the United States, which is a tool that could be implemented in the low-income countries in partnership with high-income countries in the field of training and providing of surgical services. So starting by telemedicine will help improving and implementing such an initiatives. Then part of the opportunities as well, the partnerships and collaborations. I think in our context at the moment, most of the global organizations are willing to support and help. And we have some of the international partners like David Nott Foundation. They started to collaborate with University of Al Jazeera, and they did some of the pediatric surgery center there. And they are doing some capacity building for the surgical staff. And there is the Pan-Africa Surgical Healthcare Foundation as well. They did the forum last year and this year. This is a forum for African countries and the Minister of Health and the key stakeholders of the African countries, where they meet and discuss about how they tackle the regional global surgery issues and how they manage and to support and to mobilize some of the resource among them. And as well, you have the Sudanese Consortium for Surgical Development, is an organization working toward achieving the accessible and high quality surgical services in Sudan. As we mentioned previously, we are driven by the mission that's set by our greatly Mr. Muhammad Abbas, and we will continue this vision till we achieve what we are driving to. Another opportunity is a new set of work and new direction at the moment, especially in the conflict and trauma context, and military and civilian trauma care integration. This is an initiative at the moment going on by the Program of Global Surgery and Social Change at Harvard Medical School in collaboration with WHO and with most of the willing to implement countries, especially in Africa, are in conflict setting. And I think this conflict setting is the main facilitator based on our previous researches. One of the main facilitators to start a military-civilian integration were either disaster or a war. So like our context at the moment is the best context to start combining the military and civilian trauma care, because the military have these facilities, they have the infrastructure to reach out and to support the casualties, and the civilian, they have the capacity to treat and to manage. So the assumption is the military have the access even for like the air ambulance they can do, and they have like a 4-wheel drive cars they can reach out to everywhere and can support and take the casualties. And with the collaboration of the civilian, they can reach out to the nearest trauma care center and they treat the patient. So this is an area where we can like establish connection and work as well. And again, the academic initiatives is an opportunity. The academic initiative, especially the Sudan Medical Specialization Board, they have one of the most unique training program that has research by the end of the training. This research is carried across the country by the registrars and those on training. And I think if those research is being monitored well and directed toward the need of the country, we will be able to gather probably good data, and we will be able to pursue fund for these researches as well. And as well, the Sudanese universities, the academics has a huge role in the research, and we wish to see in the future Sudanese universities taking the lead in global surgery units and achieving the global surgery research landscape, where we can prioritize based on the research. We can set our priorities, we can set our funding agency, we can apply for grants and fund, we can implement, we can track changes. Finally, the global surgery advocacy is needed, especially in our context at the moment. We have lack of access, lack of provision, lack of infrastructure. And in order for us to receive fund, to receive support, to receive and to train our people, we need to advocate for our situation. We need to be the one who advocate for themselves. We don't need to just wait for people to come and advocate for us. So we are the one who are suffering by our condition. We need to be able to reflect our condition better. In order to do this, we need to do situation analysis studies. We need to study what we have at the moment so we can continue forward. Before the, this is the second to the last topic, is the academic and research initiative in global surgery, why it is important and how we can tailor it to Sudan. As I just mentioned, the academics and research is very important for priority setting, for reflecting the current situation, for attracting fund, and for the implementation as well. So research initiatives help identify the gap and set the priority for surgical care. There is a very large unmet need for surgical care in low-income countries. We don't have a study in Sudan yet disclosing the unmet surgical need in Sudan. And this is a study in sub-Saharan Africa, speak about the unmet need in sub-Saharan Africa in general, but there is no context of Sudan per se. And along with the research, we need the academic programs to build a local surgical capacity and understanding of research. These local programs should be a master program, PhD programs that attract, fund, develop surgical workforce who are the one who may implement these interventions and developments. Then we have trainings and fellowship and mentor programs. For the trainings, fellowship, and mentorship programs, it is very important for generating leaders, generating people who will advocate for the surgical system of Sudan, who will implement, who will work forward toward developing the Sudan surgical system. The SCASD is lucky to announce the first professional fellowship program that is starting next week, probably next week or the week after. This fellowship program is tackling the surgical leadership, surgical research, and surgical system implementation. So like such programs will generate high quality people who will change the future of surgery in Sudan in the future. And research and evidence to advocacy, to advocate for increased support. We need this one. So study on cost effectiveness of surgical help advocacy toward funding allocation. Like this studies where they say like 33 million individual face catastrophic expenditure paying for surgery, anesthesia annually. So in Sudan, we have most of the surgeries out of pocket payment, and there is no study so far about telling about the surgical expenses in Sudan in the whole country or the general. And investing in surgery is affordable, as affordable from the context of the government. It is better to invest in providing surgical service rather than dealing with the consequences of not providing for surgical service. Especially they say, like most of the economical studies says, paying $1 investment in surgery will return by $9 to $20 in the future. This is the analogy by which if you have, for example, someone who has a long bone fracture, and this fracture, the payment is out of pocket expenditure, and this man, he is, for example, the provider for his family. He need a recovery time, and he will be unable to provide for his family. Here is the family will fall into poverty, and children take out of the school due to only this one fracture bone. If the government, or if there is funding to support just fracture of this bone, this family will not get into the poverty, and the children will not go out of school. So this is the context of how the investment in surgery will pay back. So, and again, the most importantly is the research capacity building for the academics and for the surgical workforce. Research can help develop solutions, and academic partnership can provide training, capacity building, and technologies. So regarding the research capacity building, we have done a study on strengthening research capacity within postgraduate surgical training program. And most of the issues was access to research resources and databases. Those are the main issues, challenges. And again, the study done by Professor Rashid and his teams, the candidates, the third most challenging thing was the research opportunities. So there is a good attitude toward research, candidates willing to do research, but there is a need for support from the system and fund, and the academics involvement and the university's involvement as well. So the intervention plan is to tackle the national surgical research program in a three level, in individual level, institutional level, and national level. Individual level from the research leadership and the PhD students, or provision of PhD master programs and research assistant positions, data collectors, and everything. Building the capacity for those people is very important, including the universities, postgraduate colleagues, and hospitals as institutes where there is research is run. Capacity building for these institutes, and management and plans for how to apply for grants and how to attract grants, how to manage grants is very important. And on the national level is setting priorities, working on the ethical review committees and boards, which is already done by the Sudan Medical Specialization Board and the Minister of Health, is important. The integration of those three levels is very important for them to work together. These national bodies should put the priorities and provide the guidelines. Those institutional level should guide the candidates, and those candidates could implement the research and execute the research. So this harmony is very important for us to achieve the academic global surgery and surgical development through the academic research. Finally, we are, finally is the role of advocacy for developing global surgery and surgical service. and allocating of funds. So most of the surgical issues is fund related. And advocacy is crucial, and it is to put your agenda in others people agenda, or and prioritizing your issues in others people agenda. And we can, if we understand that surgery is part of 70% of all the diseases, like in 70% of the disease from the start till the like the resolution or the death of the patient, is it needs 70% of the patient needs surgical intervention. So if we understand this, we can advocate even for surgical intervention or for surgical fund among the TB patients, because the TB patient, he needs airway, he needs oxygen, he needs ventilators, he needs this stuff. So those are part of the surgical sets interventions as well. So if we just understand that the surgery is part of 70% of all other diseases, even the chronic diseases, we can promote for this across the programs that have funding already. Like there is fund for TB, there's fund for malaria, there's fund for HIV and hepatitis. Hepatitis might need surgery in some of the course of the disease. So understanding this, we can put our issue, our surgical issue in others people agenda. And research and evidence are essential foundation of effective advocacy. If we need to advocate, we need to have research, we need to have data provided, and then civic society engagement and collaboration. As we mentioned at the beginning, the global surgery is a multidisciplinary and transsectorial implementation and involvement. So we need to involve all the others organization in place. And in this context, there is the global, the G4 Alliance, the main advocacy platform globally for global surgery. And the Sudanese consortium is part of this global alliance, where we can connect with all those members and we can provide and support Sudan through our connections to those members. All we need is data about our context, so we can present it, we can advocate through our data to those global organizations. Global surgery still receive limited funding from major donors compared to other global health issues. Advocates can work to integrate global surgery into the existing global health initiative like the Global Fund. As we can see here, this is how the fund is there and how we can finance our surgery with those program already has fund. And strong continuous advocacy is needed to increase the political priority and funding. Increase political priority and funding is very important. We need to include and to involve key stakeholders and the key priority stakeholders in the country, in Sudan, to be able to advocate for the need of surgery in the political agenda. And this is a framework of how we can set the priority of the surgery across the policymakers, starting from the actor power and the idea generation, political context, and the issue and the characteristic of the issue, how to implement, how to advocate, and how to prioritize the surgery across the other agendas. And this is a very brief highlights about the global surgery, about what we have. And the team from the Sudanese Consortium of Surgical Development will take you through their plan and what they are willing to do in the future to tackle this issue. Thank you so much.
Thank you, Mohammed, for such an informative presentation. Okay, we will open a space for question and discussing, but let me share with you okay. Okay, here is the strategic plan of our department, communication and advocacy department. We are working on multiple strategies to achieve our aim, uh, which is to advocate for an efficient Sudan surgical system. But the most important thing that we want to highlight is the NSOAP, Sudan NSOAP advocacy. Uh, we need to get to many outcomes, mainly the harmonized effort to improve our surgical system. We should be wondering about the NSOAP, what is NSOAP and why it is important, and how we gonna make this. So I would like to introduce Amna, the Communication Advocacy Department member, and NSOAP Advocacy Project member, team leader of situation analysis. Welcome, Amna. The mic is yours to briefly outline this.
Thank you, Ilab. Is my voice clear? Can you hear me?
Yes.
Yeah.
Okay. So my name is Amna Makossa. I'm the leader of the NSOAP project. It's part of the communication department, as Ilab just mentioned. We'll just go through NSOAP. What do we mean by it? And we have like a team. We will share with you our steps. What did we do so far, and like our major plan. What are we trying to do, or how NSOAP is going to come together in the following year? Okay, so first, NSOAP is it's referred to shortening for National Surgical Obstetric Anesthesia Planning, which is a process that offers ministries of health a path to integrate the surgical planning into their overall national health strategy, which basically it's like a manual or a guideline to try to improve our services, especially the surgical deliveries, or the strategies that we are embodying in Sudan. The NSOAP the NSOAP manual is a comprehensive plan methodology. Yeah, go to the past slide. Yeah, just for 1 second. Okay. Okay. So what I was saying. So the NSOAP manual is a comprehensive planning methodology for the government to increase the capacity in safe surgical, obstetric, and anesthesia care. We just want the care to improve. We try to find all the holes or all the lackings in the system. Some of them Dr. Mohammed Al-Sadiq already mentioned at the beginning. So we're just trying to improve our care delivery in the general. Okay, so why why do we want to create the NSOAP manual for Sudan? So the NSOAP it focuses on the diseases amenable to surgical care. We want to implement these plans so that Sudan can tackle the health burden, or like improve some of the burden that we're currently facing. Could be caused by different conditions that require surgeries, and the situation, as you all know, is even worse now due to the war situation. So we're just trying to assess our current situation and try to build a new manual to help and improve the system. So the NSOAP, it also reflects the Sudan commitment to the global goals. It's a global project. Some of the projects that will be also included in the NSOAP, the universal health coverage, and the SDG, which is the National Sustainable Development Goal. So it's a collaborative effort. We try to involve the global and the national aspects. This is a map. See, these countries are the one with the green color. They have actually completed their NSOAP process, which we're trying to achieve. The one with the purple color, they just began their NSOAP process. So hopefully Sudan will be on the map very soon. The blue color, it's the countries that are committed to the NSOAP process. Okay. So how are we going to build this manual, or what are the steps to build this project? First, we should revise all the NSOAP implement or the implementation of the NSOP. We'll look at the projects from in different countries. Then we should do the stakeholder mapping. Some of them we already mentioned. For example, the Ministry of Health, which is a key stakeholder in this project. Literature search. We will try to find different researchers that take the NSOP, talking about the NSOP, the implementation, the difficulty that we might face. So thorough literature search is needed. Then communicating the plan to involve all stakeholders. And it's followed by the situational analysis. So situational analysis, it's actually we began the situational analysis. We're trying to build the preliminary draft for situational analysis. Me and all the NSOP team. So you're more than welcome. If anyone here is interested now about NSOP, you want to join, we can communicate us after the presentation. After the situational analysis, there should be like a communication of the result of the draft that was made. It could be through conferences, and then the grant proposal writing. Okay. The next step or the next phase, it should be led by the Federal Ministry of Health of Sudan, and our association will also help with monitoring and implementation of the project. So at the beginning, we will help to facilitate the communication and the connections of different parties that we might have contacted them already at the beginning of the NSOP manual writing. Then we will help to draft the NSOP manual. Then the SDSD will support the implementation process, the NSOP project. Then we will help. I'm sorry. Okay. Then we will help in monitoring and evaluation, and we'll see the quality assessment of the process. Next, we will help in presenting the outcomes, and we'll see the impact through researchers. So the whole map of our vision, we're trying to make it happen, or like do all the implementation process and see hopefully the fruitful outcome by 2023. We have a small slide. Can you share it as well? Okay, yes. This is our team member. This is me, the middle. We have also Ilaf, Tasneem, Rawnaq, Abdurrahman, and Duha. And Malad, they're all joining with us the meeting. I think we have another slide, right, Ilaf? Next, you can share it with us. So it's just just sharing. We're just trying to share the main ideas. So the NSOP, it's directly assessing the infrastructure, the workforce, and the service delivery, the financing, as well as the information management of Sudan. And the last slide is the parties that could be also a collaborator in the NSOP project. We can share with them. Yes. So the first one is the Sudan Consortium for Surgical Development, our association, and of course the Federal Ministry of Health, the Medical Specialty Board, and different global parties and educational parties that could help us hopefully implementing the project. Thank you all for coming to the webinar. Hopefully you enjoyed it. We look forward to anyone who wants to join us. You can contact us there.
Yeah, thank you, Amna, for the nice presentation. As she mentioned, he is a team behind the scene who organized this webinar and whom are working on the NSOP advocacy project. All of them were here, I guess. You can say hi. And thank you so much for attending this webinar. We hope it is an informative and you enjoy it. You can scan code to access our platform in social media, and always you can contact us and reach us through our email. And don't forget to fill the feedback form. Yeah, drop in the chat box. Don't forget to fill the feedback form for more to get your feedback and to improve for our next webinar. Thank you again, Prof. Rashid, for attending this webinar. If you have
yes, please, Professor Rashid, if you can give us some remarks.
طيب thank you الحقيقة I'm really enjoyed والله presentation والايديا ذاتها محمد really good. حقيقة عندي just comment واحد to one حقيقة أنا أفتكر إنه we need some integration between the higher medical Ministry of Higher Education والسودان Medical Specialization Board والMinistry of Health والسودان Medical Council. أنا أفتكر the four has to be really في كوميتي بيناتهم عشان تجدش يعني Ministry of Health يمكن عندها مثلا 100 خانة بتاعت هاوس اوفيسر، تقول للهاير اديوكيشن ما ممكن تعمل لي تخرج لي 1000 هاوس اوفيسر. انا افتكر ده مهم جدا. واحنا في السودان ميديكال سبيشاليزم برضه عندنا when they come and sit for the exam، يعني احنا عندنا الستاندرد ده مهم جدا. لكن بفتكر انه يعني the chaps who come to sit for the هناي يعني الباس مارك بيجت في فيرست بارت فيري لو، مرات 15 و 20% ولا كده. فانا افتكر بنحتاج ل some sort of integration.
صح.
طيب انا ده رجع لحاجه مهمه جدا اللي هي حكايه ممكن تسميه اوديت ولا ريسيرش، لكن هو دوكيومنتيشن. ودي المشكله بتاعتنا. انا افتكر انه we don't have documentation. احنا ريسن استدي افتكر كان عملناه في 600 فايلز في الجراحه في 6 مدن، عطبر بورسودان وكده. عملت الدكتوره تيبيان معها هاوس اوفيسرز وي جاست لوك ات ذا فايل اوف ذا بيشنت ونشوف انه هل الاسم مكتوب رباعي، الايدج، يعني الداتا البيزك دي. فحاسه دي تقريبا يعني بيبر تو بي ببلش يعني خالص. لكن الفايندينجز كانت ريلي والله فيري ديسابوينتنج. يعني مرات حتى الاوبريشن نوزت ما في شيء. ويعني جست يعني انا افتكر اهم حاجه الدوكيومنتيشن، لانه انت ذاته عشان تعمل فاندنج ولا يو هاف تو نو انت بتعمل في شنو. يعني ذا فيري بيزك ثينج انه مش كده نمبر اوف بيشنتس، مورتاليتي، موربيديتي، ولا البتاع دي. انا افتكر اللي هي يعني سموها طبعا احنا عندنا الريسيرش الخاصه بنعمله ده، لكن برضه الفهم بتاع الريجسترار والاخ ده اللي بحث كده عشان امتحنه كده ما قادر يفهم الموضوع بتاع الريسيرش ده. يعني هو جزء اساسي، وممكن يكون بالمناسبه يعني الافكت بتاعه كبير جدا، لانه حسب المنظمات العالميه دي لما تيجي دايره تعرف تعمل في شنو. يعني انا اتذكر في جابر ابو العز كل الفندنج يعني يمكن زي 3 4 مليون فتحنا بيها، كان مراكز في كل السودان. لكن كان بيز اون داتا بيجي خاشين بندخلهم اوضه الكمبيوتر عندنا كده 6000 كده الديابيتك كده الامبيوتيشن كده. يعني الزول داير يديك حاجه داير يعرف تعمل في شنو على اساس انه بعد ذاك انت you are going to improve your result. فانا افتكر يعني حكايه اكاديميك ستاف ونانا اكاديميك ده كلام قديم زمان بيقول لك اكاديميك سيرجن نانا اكاديميك سيرجن. انا افتكر حسه اي سيرجن او اي جراديويت اخصائي لازم يكون هو ريسيرش مايند. معنى شنو؟ لازم يكون بيقرا مجله. الايفيدنس بيز ميديسين ده جاي من وين؟ ايفيدنس بيز ميديسين انه يو هاف تو تريت يور بيشنت باللاست ثينج ان ذا وورلد. فانت لازم تكون عارف البي فاليو معناها شنو، مش كده؟ وعايز تعرف انه الداتا بتاعتك الموربيديتي والمورتاليتي كومبير مش كده للعالم كيف. فانا افتكر دائما يعني البوست جرادويت من بدري. انا في الطب في السودان بدا انا افتكر فيري هاي، ويعني اللينك بتاعتنا كانت مع يو كي من الخمسينات، وكان الهدف منا كله انه يجرادويت فيري هاي كاليبر دكتور تو اوفر اور بيشنتس ذا بيست ذات افيلبل زي ما قلت في العالم. فانا ريلي امبريس بالنيم بتاع الجلوبال سيرجن. احنا دايما تفكيرنا كله انه يعني وات وي دو شود ريلي ماتش اللاسing in the way دي. صح هسه في الكونفليكت دي، لكن حتى في الكونفليكت دي انا افتكر يعني هسه في لطف ورك بيتعامل during the conflict. انا افتكر في مسج كثيره بتجي، يعني الكوليرا في والدينجو فيفر والامبيتايجو دي المفروض تطلع داتا بالمناسبه. يعني احنا ما قدرنا الدبليو شو تورينا، يعني احنا بنوري الدبليو شو. انا افتكر الداتا اللي عندنا ده بيشتغلوا الناس شغل صح. فنحن وي كان دو ذس. يعني لندن سكول اوف تروبيكال هايجين بقول بتديك دكتوره المفروض تكون هنا. لندن ما فيها تروبيكال ديزيز يا اخواننا، نحن وي هاف. فانا افتكر انه الريسيرش مايند ده عند الدوكيومنتيشن ذاته. وبعدين زي ما قلت انه صح في الاخر يكون عندك داتا تو بي ببلش. طبعا ده بيتر لانه فور يور اون كارير. انفورشنتلي يمكن حس احنا ما عندنا في السودان غير مجله الاسلاميه النازك سود امريكا اللي ما شغال وكده. لكن أنا افتكر الريسيرشز الموجوده وكميات كبيره دي اهم ما فيها ترانسليشن تو براكتس. ترانسليشن تو براكتس بيجي انه في لجنه عندنا في المجلس هي المفروض تكون في اي بحث طلع مثلا في الاوبس لقينا كده في مسج بتمشي طوالي للمينستر اوف هيلث الماتيرنتي مثلا. يعني المسج بتاعت الريسيرش هاز تو هاف ابلكيشن طوالي. يعني حسنا شغلنا في السكري والديابيتس لقينا انه ان احنا الديابيتس فود ما زي العالم برا، احنا شوكه ودبوسه وابره ومسمار ومحفوظات. طيب if we can avoid this نحن we can really prevent الكلام اللي حسه شغالين فيه انه prevention is better than يعني cure. كلها ادفايس وجزمه وبتاع. الشاب سيمبل، لكن ما بتتخيل انه somebody ممكن يحصل لها امبيوتيشن لانه طعنته شوكه، كان ممكن ما تطعنه وكان طعنته كان ممكن يعمل يعني حاجات زي دي. فانا افتكر ده الهدف من الريسيرش ولا اللوكال داتا. يعني انا افتكر في كل السبيشاليتيز انت دائما يشوف يو نوت انه في بروبلم، يو ستدي ذات بروبلم and you put the solutions و these solutions has to be يعني خشت في الجايد لاينز. اخواننا الانترناشونال جايد لاينز اللي بتتعامل دي ما سوتبل مرات عندنا، يعني you have to modify it according to our society هنا. والكوست افكتيف ده مهم لانه احنا بالنسبه لنا اي حاجه يعني بتصرف فيها قرش مهمه. يعني لما عملنا مثلا الدريسنج بتاعنا بمويه الماسوره وخلينا الصيلاين وفرنا ملايين. يا اخي جاز السلف المتحط عندي بكم؟ لكن اخر حاجه لقينا انه التاب ووتر النظيفه بنعمل لها كرشل وانا دريسنج لنا 15 years there is no difference. فانا افتكر انه الفهم بتاع الريسيرش ذاته حقه يتغير الى انه انت يو ار جوينج تو improve the setting بتاعك كويس. نمبر 2 يو كان اتراكت هيلب لانه الزول بعرف انك انت بتعمل في شنو، هو الزول اللي بيساعدك. فشكرا لكم حقيقه. يعني انا افتكر this is really very والله very impressive reading انه يعني I heard a lot of new information ما في كلام. وافتكر يعني المرحوم محمد عباس زي ما قلت يعني he said one aspect بتاع افتكر حقول ده continue ان شاء الله يكون weekly ولا 2 weekly وتدرس different disciplines يعني ما سيرجري بس. شكرا لكم.
تسلم، شكرا جزيلا يا بروفيسور. احنا وريت اوت برضه للفيرذر بلانز و برضه ناخد رايك في كل الموفمنت بتاعتنا اللي ماشيين عليه قدام ان شاء الله. لو في زول عنده اي كومنت او اي سؤال برضه ويلكم.
يا محمد كيف الأحوال؟ Thank you so much guys for the lovely presentation. Can you hear me?
Yes, I can hear you.
Yeah, the presentation was very insightful. Thank you so much for you and for the rest of the team. Actually, I don't have a question. I just want to ask, I have been a big fan for the platform for a while now. I have been following most of your social media platforms. I just want to ask, what is the involvement of ops in gynae now? Because I can see most of the participants here, I think they are surgically interested. I am ops and gynae doctor myself. I would be really interested to help and join. If you have any current project about ops and gynae and surgery together, I would be really interested to jump in.
أول حاجة شكرا جزيلا يا دكتور أحمد الفاتح. شكرا إحنا لنا سعادة الشرف بانضمامك لنا الليلة في السيشن. الانسوب بروجرام ده البروجكت بتاع الناشونال سيرجيكال بلان ده بروجرام انكلودينج الانستيست والاوبستريشن وكل البوليسي ميكرز. افتكر دي اكتر حته انت يو كان امباكت فيها مور. بعد ذاك من هنا احنا وي كان go through the الفيس بتاع الاسسمنت مثلا. وكنا نكون دايرين نعمل البيس لاين داتا بتاعتنا، هنكون دايرين نعمل اسسمنت ريسيرشز بتاعت اوبستريك، ريسيرش بتاعت انستيزيا، ريسيرش بتاعت انفراستراكشر في السيرجري ان جنرال. فدي حتات بنكون محتاجين فيها خبرتك، بنكون محتاجين فيها النولج بتاعتك، محتاجين فيها الجايدنس بتاعك. فأذر ذان الحاجات التانية يعني leadership capabilities بتاعتك والانسايت بتاعك في كل الحاجات التانية. فنحن سعيدين جدا جدا بوجودك معنا ونريتش اوت لك طوال.
Yes, thank you دكتور محمد الفاتح. عندنا الكونتاكت بتاعتك وإن شاء الله حنتواصل معك بعد الويبن. بهاء الدين is raising his hand.
السلام عليكم، مساء الخير. طيب actually أنا I have two questions. بما إنه الليلة معانا سعد البروف رشيد، فدي فرصة كويسة إنه الواحد يستغل المساحة دي. والسؤال الثاني اللي هو للدكتور محمد الصادق. بالنسبة للبروف، طيب أنا مؤخرا حاولت أشوف إذا كان في أي surgical national policy related مثلا للسودان. حتى إذا ما إذا كان مثلا في أي policy brief related للحاجة دي بتوضح أي financial models أو health insurance مثلا system could be implemented in Sudan during the current context. Actually لأنه لاحظنا before مثلا 2 or 3 months كان دكتور هيثم سعادة الوزير اللي هو كان وضح البيردن الحاصل في السودان والحوجة اللي هو للسبورت، ما بس للمستشفيات، للصحة ككل يعني. فقبل فترة كنت بتناقش مع دكتور محمد الصادق إنه في جهات يعني كثيرة وكبيرة organization هي willing يعني to help، لكن داير الحاجة دي تكون مثلا مقدمة من جهة يعني فورمال وسيرتي. فهل في أي financial models أو health insurance system اللي إحنا بنقدر to implement الحاجة دي يعني؟ وهل ذاته يعني مثلا الجهات المختصة في السودان يعني عند الابيليتي مثلا للحاجة دي؟ بالنسبة للسؤال الثاني لدكتور محمد الصادق، أنا طبعا متابع أو من البيج فانس بالنسبة للكونسورتيوم أو متابعة من التأسيس لحد اللحظة. فسؤالي related للإنوفيشن والتكنولوجي أو يعني بخصوص التلميديسين اللسي، إنه إذا إحنا put in our mind the limited resources حقت السودان الحاصلة، هل في رول ولا تلميديسين ديجيتال هيلث بلاينج مثلا إنه إحنا نعمل لها implement برضه في السودان؟ يعني هل في recent innovation للسيرجيكال تكنيك ولا التكنولوجي could be adapted during the current context حاليا يعني؟ آه، او حتى يعني انظمه مثلا هي كانت مطبقه في دول هي عندها نفس الكونتكست بتاع السودان الحالي. شكرا.
طيب يا الحقيقة يعني السؤال بتاعك ده جميل جدا. اكزاكتلي انا يمكن ويك اجو كنا في بروجكت اللي هو مع الورد دايابيتس فاونديشن، بروفيسور حمالي التوب حقيقة معانا في القصة دي اللي هي قدمناه، واللي هو انه هاو تو يعني بريفنت ولا ريديوس الديابيتك فود. فالبرنامج الحقيقة مشينا كان الشمالية ونهر النيل، والهدف منه كله فندد بالمناسبة بارشيلي من الورد ديفيس فاونديشن، الصحة الولائية والصحة الاتحادية يعني ملتي كان. لكن افتكر كان انه اخترنا مثلا 7 مدن حول دنقلة، من كل مدينة جبنا 2 نيرسز، و7 مدن حول عطبرة، ونفس القصة يعني زي 14 زي ريزايدد فور 1 ويك، حاجة زي 8 يوم 9 يوم كده بنديهم محاضرات الصباح، بعد ذاك هانس اون وكيف تو بريفنت الكلام اللي قلته قبل شويه اللي هي تو بريفنت الديابيتك فوت، وحصل لو حصل ايه اللي يعملوا يعني بروجكت انا افتكر جميل جدا انه يهب انه حسه قدمناه برضه لمنظمه ثانيه على اساس انه تفندت للبحر الاحمر وكده. وبالمناسبه امانه بقول انه يعني if you have جزء داتا يعني ده حسه عندنا ثاني برضه بروجكت، البروجكت الثاني ده مثلا يعني to follow for 1 year كويس مانثلي دوكيومنتيشن عشان نعرف هل التيتشنج اللي عملناه ده افكتيف ولا ما افكتيف. يعني في النهايه القصه كلها احنا عايزين تو يعني ريديوس مينيمالي الريت اوف ابيوز عشان عندنا بقى داتا كلها وكده. فانا يخلي في كل مجال الحكايه دي يعني كان بيضا، لكن انت اهم حاجه زي ما قلت لك انه يكون عندك بيزك داتا، حتى بعد ذاك تيجي الكويشن، بعد ذاك توري البلان بتاعتك اللي انت عايز تعملها تو ريديوس الحاصل شنو. وعجبني الحقيقه الاخ محمد الفاتح، لان انا بفتكر دائما انه الهيلث في اي دوله، انا بسال سؤال واحد، وريني بس الماتيرنال مورتاليتي والانفانت مورتاليتي، ده اليارد ستيك بتاع الهيلث في اي حته وفي اي ولايه. وحتى انا كنت بقول والله حقول الزلمه اللي عنوان للولايه والحي يقول لي يا اخي عندنا مورتاليتي كده ماتيرنال وانفانت كده، ده نشوفك ان شاء الله بعد سنه حتورينا الحاصل شنو. انا فعلا يعني الانفولمنت بتاعت الانستيزيا والاوبس وبعدين كل السيرجيكال انا افتكر يعني ده بوديوم جميل جدا افتكر. شكرا.
شكرا خالص يا بروف. بها بالنسبة للسؤال بتاع النيو تكنولوجي، أنا recently I came across one of the innovation done by organization called Betterfly. It is an organization part of the G4 Alliance. They provide point of care ultrasound with a very small device connected to a telephone. And you can track out and check the trauma, the fast scan, the trauma scan. You can do it with a very small device and have it on your phone. You can diagnose if this patient in need for laparotomy or not. And at the same time, the device is very cheap and provided by a lot of organizations that can help and support. They provide training as well, and they provide the device. So this is one of the things that we can provide, we can think of, and we can do if we have a data, as Professor Rashid said. If we have a data of the number of injured people, the number of trauma, the number of laparotomy we do, and the number of laparotomy that we just do for exploration and we didn't find anything, and the impact of the point of care ultrasound. If we have this data, we can apply for grants, we can have these grants, we can train our people, we can have it, especially in the context of our conflict at the moment.
شوف والله بالنسبه للتكنولوجيا اوكي، لكن انا اوريك شفت الميديسين ده ويل نيفر شفت ديليت الهيستوري بس سايد اكزامينيشن. شو الهيستوري والاكزامينيشن ديل وانت ديفلوبد باي براكتس وفيها الكوميونيكيشن مع البيشنت. صح الديفايسز والتكنولوجي والهيلب اس، لكن ويل نيفر ريبليس الاثنين ديل. وانا افتكر الادفانتج اللي بقوله دائما للنواب عندنا هنا في السودان انه لغايه حسه الهيستوري والفيزيكال اكزامينيشن بديك ريلي الديسيجن ميكينج وبيقلل لنا الانفستيجيشنز. يا اخوانا احنا لغايه حسه عندنا ادفانتج كثيره عنه، يعني اوردر بيس انفستيجيشن عن الانفستيجيشن غير انها اكسبنسيف ودائما البيشنت زي بيت ولازم تعرف انه شو مش كده. لكن at the end of the day بتلقى انه الاثنين الاولانيين ديل يعني هن ريلي اليارد ستيك بتاعت اي بالمناسبه يعني مانجمنت والديسيجن ميكينج سبيشالي في السيرجري والاوبس والحاجات زي دي. شكرا.
بالضبط. That's right. Thank you so much. Anyone else has any comment, any question, any insight? Ilaf, do you have any closing remark? Whereas, okay, then I will thank you all and thank you so much. We will continue our webinars in the future and we'll keep connecting with you. We'll update you with all the plans, all the movement for the future and toward Sudan supported and with good quality surgical service, inshallah. Thank you so much.